This is Dr. Mandy Binning. She's the Chief of the Division of Vascular Endovascular Neurosurgery and Director of Stroke Programs at the Global Neurosciences Institute. She's an associate professor at Drexel University School of Medicine and board certified in neurological surgery. Dr. Binning completed her medical training at the University of Colorado School of Medicine and a fellowship in endovascular and cerebrovascular neurosurgery at the University of Buffalo. She specializes in both minimally invasive endovascular cerebrovascular neurosurgery and open vascular microsurgery and is a fellow of the American Association of Neurologic Surgeons. Welcome, Dr. Binning.
Good morning, and thank you for having me. Can everyone hear me and see my screen?
Yes, we can. Thank you.
Thank you. And I'd like to thank Dr. Dresser for the invitation to speak. I'm really going to be speaking about the new 2022 guidelines for hemorrhagic stroke with a focus on surgery. I have no disclosures. Hemorrhagic stroke accounts for approximately 20% of all of the strokes nationwide. That said, the burden of disease is quite high, with 30-day mortality of about 40%. And patients who have hematoma volumes of 30 cc's or more, only less than 10% of those patients return to functional independence. And as a whole, patients with hemorrhagic stroke, only about 10 to 25% return to functional independence. So it's quite a morbid condition. Not to mention the complications associated with prolonged ICU stays, such as ventilator dependence, need for long-term nutritional support, as well as secondary infections such as pneumonia and skin breakdown. I like to think of hemorrhagic stroke as any cause of a head bleed that's not trauma, with hypertension being one of our most common causes. That said, as you'll see in the talk, I don't like to chalk every hemorrhage up to hypertension, and we have to be careful to identify the source of the hematoma or hemorrhage in each case. Many of my slides are adapted from the 2022 AHA guidelines and from their slide deck because, even though this is a surgical talk, a lot of the management of ICH is that initial management of their blood pressure and anticoagulation. So we want to know from time of onset what the time of onset is with any stroke. Did the headache start 2 days ago? Did it start immediately prior to presentation? Is there focal neurological deficits? What is the patient's medical history? Do they have hypertension? Are they anticoagulated? Do they have liver or hematological disease that make them more likely to bleed? And any sort of substance use. As in the last talk, you'll see that I'll be discussing levels of evidence, with class 1 being based typically on randomized controlled trials and as strong evidence of benefit, whereas class 2A, there's moderate evidence and we think there's a benefit. Then everything that's 2B, we think it's reasonable, but the benefit is unclear. And then anything less than that, either there's no benefit or harm in that intervention. So once ICH is diagnosed, we focus on the acute resuscitation. Well, really, as a patient wheels into the emergency department, it's about ABCs: resuscitate the patient, make sure the patient's stable to go to CAT scan. And then once we identify the ICH, then we deal with blood pressure, ICP management, and reversal of any potential coagulopathy. In addition, we want a focused neurological exam. And oftentimes this is an NIH score, can be GCS, and then basic laboratory work, including coags. Even though the AHA guidelines say test specific for DOACs, we don't wait for 10A levels. If the patient has taken their DOAC in the last 24, 48 hours, we're going to reverse that. Let me just go back. And then we also want a tox screen, pregnancy test, and cardiac labs. As I said, a plain head CT is what we want as our initial diagnostic tool, but based on the pattern of blood, maybe we want CT angiography, the age of the patient, and then if it looks like maybe there's a aneurysm, we may go on to do angiography, and that's where this slide comes in. If there's spontaneous IVH, subarachnoid hemorrhage, we're going to do a cerebral angiogram. But for, you know, the 70-year-old patient with a lobar hemorrhage, maybe not necessary. Maybe we do MRI to make sure it's not a tumor. So really, each patient needs to be looked at individually and decide which studies are the most appropriate to identify the cause of the hemorrhage. The reason why I said age 70, what we're thinking about is amyloid angiopathy in lobar hemorrhages in those patients. It is an important note that up to 80% of patients who present with any kind of spontaneous intracerebral hemorrhage will have hypertension. And that's important because we don't just say, oh, they have hypertension, this is a hypertensive hemorrhage, and then move on. You know, a ruptured aneurysm, that patient is going to have hypertension because their head hurts, they have meningismus, they're probably vomiting, maybe they have increased ICPs. So we really have to look at the pattern of hemorrhage, identify the cause, and not just say it's a hypertensive bleed. Hypertensive bleeds have very characteristic findings on CT. And so it is important, though, that we recognize the blood pressure is elevated and we treat that. And the rationale for that is that if the blood pressure is elevated significantly, there's increased risk of hematoma expansion or rebleeding of a vascular lesion such as AVM or aneurysm. And, you know, there is some detriment to lowering the blood pressure too much, especially if the patient has elevated ICPs. We don't want to lower the cerebral perfusion pressure, but we want to usually maintain a cerebral perfusion pressure above 60 until the ICP can be treated. And also we do have to consider end organ hypoperfusion, that we often see acute kidney injury in these patients once we actively lower their blood pressure to prevent rebleeding of the stroke. So these are the guidelines that just came out this year. And 2A evidence is we want smooth titration of the medication for sustained control of blood pressure. So we no longer want to just give a bolus of whether it's a beta blocker or, you know, hydralazine, labetalol. We don't want to give a bolus, bottom out the pressure, have it peak again. We really prefer drips for continuous, smooth, sustained control. As I said, I have no disclosures, but to me, the most titratable and easy on, easy off drips tend to be the calcium channel blocker drips, such as nicardipine or clofidipine. Another 2A recommendation is initiating treatment within 2 hours of ICH onset and reaching a target within 1 hour. Now, these recommendations always give some leeway with the understanding that it takes time to put in an order and get a drug out of the Pyxis and get the IV going and get the medication in. And so these recommendations give leeway for the logistics of a hospital, but really once the ICH is diagnosed, you really want to get the blood pressure down, and ideally you should be able to do that in less than an hour. And you don't want to wait up to 2 hours once the ICH is diagnosed. If the patient presents with systolic blood pressure of 150 to 220, the recommendation is for acute lowering of blood pressure for a target of 140 in a range of 130 to 150. If the patient has a large ICH with increased ICPs, lower blood pressure lowering is not well established, again, because of the cerebral perfusion pressure issue. And if the patient has a mild to moderate ICH and systolic greater than 150, lowering the pressure below 130 is considered potentially harmful. So blood pressure control and reversal of coagulopathy are two first moves to prevent hematoma expansion. We know that patients taking oral anticoagulants constitute 12 to 20% of patients with ICH, and that portends a higher likelihood of hematoma expansion, increased risk of death, and poor outcome. What is this based on? Many of you have probably heard of the ICH score. This is a score that bases the prognosis for the bleed on factors GCS, age greater or less than 80, location infrasupratentorial, the volume of the ICH greater or less than 30, and then the presence or absence of intraventricular blood. As you can see, a score of 3 or higher is a 75% risk of mortality. So our goal always is to prevent hematoma re-expansion. We can't do anything about the initial insult, the initial hemorrhage, but if we can, we want to prevent it from rebleeding or re-expanding. So the primary mechanism of injury, of course, is the initial insult, the initial hemorrhage, but then this can result in herniation, hydrocephalus, increased intracranial pressure. It says 0 to 6 hours, but really that can happen anytime during the hospital course, and we monitor for that with constant Q1 neuro exams. And then secondary injury tends to be from cerebral edema, inflammation, and toxicity from blood products. So in terms of anticoagulation reversal, patients who are on vitamin K antagonists such as warfarin, there's class 1 evidence for reversing any patient with INR above 2 with 4-factor PCC and IV vitamin K. For an INR less than 2, that's factor 2B evidence. I'll say for me personally, if I have a small stable ICH and an INR of 1.5, I would probably just do vitamin K. I'm not going to subject that patient to PCC. If I have an INR of 1.5 or 1.6 and the patient needs a drain or surgery, I would reverse because I want hemostasis during surgery. So I think that 2B recommendation it's nuanced based on the clinical picture. If the patient is on a DOAC or factor 10A inhibitor, you want to know when the last dose was taken. If it's in the last 48 hours, then PCC is a 2B recommendation. Or if you have the drug-specific reversal agent, such as in this case, the trade name is Praxibine or Adnexa, which is in the next recommendation, that is 2A evidence. I will say, though, that even though these are specific reversal agents, many hospitals don't carry them because of the cost, and PCC has been shown to be effective in reversing bleeding for anybody who needs for surgical bleeding. So in most of our centers, all we have is PCC, and I'm very comfortable operating with reversal after PCC. And then if the patient is on heparin, whether it's unfractionated or low molecular weight, protamine is the reversal agent, but it's a 2A recommendation for unfractionated heparin and not for Lovenox. That's 2B. What about antiplatelet agents? So this again goes to whether or not the patient requires a drain or neurosurgery. If the patient requires a surgical intervention, then platelet transfusion can be considered for hemostasis, as well as desmopressin or DDAVP. And if the patient does not require surgery, platelet transfusion is considered to cause potential harm. I do still tend to give desmopressin in those patients who don't require surgery, just to try to decrease the risk of hematoma expansion. Other agents such as recombinant factor 7A and TXA, their usefulness is unclear. And so that's a 2B recommendation for their use. Once the ICH has been recognized and you've managed the initial blood pressure and coagulopathy, then the patient tends to move from the emergency department to an inpatient care setting. And it is recommended, a class 1 recommendation, that the patient is in a specialized inpatient unit. It needs to be an ICU. And the patient needs to have expertise, caregivers with expertise caring for them. So that could be and needs to be nurses with stroke competencies and education. If the patient does require neurosurgical intervention, EVD, craniotomy, clot evacuation, the patient needs to go to a center with neurosurgery. And if the center does not have ICU team that's comfortable even with an ICH patient that doesn't need surgery, the patient should be transferred out for expertise. So I'll go through these quickly. It's recommended that ICH patients are treated at a center with standardized order sets to really to make sure that we don't miss any of the guidelines for care or metrics, that they get a swallow screen, that they get Q1 neurochecks, telemetry, continuous cardiac monitoring, and then again have adequate nursing staff. In terms of DVT prophylaxis, SCDs are recommended immediately. Low molecular weight heparin or unfractionated heparin is a 2A recommendation. I tend to prescribe this once I have a stable head CT, and that is usually, I kind of skipped over this. I always do a stability scan within 24 hours. If that scan is stable, I don't tend to get serial scans unless there's a change in neural exam. So once I have that stability scan, I'm very comfortable starting DVT, chemical DVT prophylaxis. In terms of glucose management, based on the nice sugar trial, there's a target for glucose less than 180. Really intense glucose control is not recommended because of the risk of hypoglycemia. And then normothermia is recommended, but hypothermia is not. This is a new recommendation, and it used to be that we would extrapolate from the trauma guidelines. If a patient had an ICH, we would do 7 days of anti-epileptic medication. But now if the patient does not have any suspicion of seizure, anti-seizure drugs are thought to be of no benefit. If the patient had a witness seizure or a fluctuating neurological exam, then EEG and anti-epileptic medication is recommended. Okay, what about neuroinvasive monitoring and intracranial pressure monitoring? So if a patient with a ICH or IVH and hydrocephalus, ventriculostomy is recommended, class 1 evidence to reduce mortality. Corticosteroids are thought to be of no benefit. Now, in terms of improving outcome, you're going to hear a lot in this talk about mortality versus functional outcome. ICP monitoring is a 2B recommendation to improve outcome. Hyperosmolar therapy, such as mannitol or 3% saline, that is a 2B recommendation for cerebral edema. And then bolus hyperosmolar therapy can be considered transiently to reduce ICP. So what we'll often do is, maybe I'll give mannitol on the way to the OR, or if a patient comes in hyponatremic, I will shoot for a sodium goal typically of 140 just to help decrease cerebral edema. What about surgical intervention? So minimally invasive surgical evacuation for ICH, which I'll show an example of, again, is a 2A recommendation to improve mortality. Minimally invasive thrombolysis or clot evacuation to improve outcome is its uncertain effectiveness 2B. And then again, 2B is choosing MIS over craniotomy. There is no recommendation that way. So it's really the surgeon's choice, and it depends on the area, location of the hematoma as well. So minimally invasive clot evacuation is not superior to craniotomy or craniectomy, but you can choose it. It's reasonable to choose it, is what that recommendation says. So this is a 62-year-old female who presented as a stroke code. You can see on the head CT a large right basal ganglia hemorrhage with 12 millimeters of right to left midline shift. The GCS on arrival was 12, and the patient was sleepy and hemiplegic on the left. She underwent minimally invasive hematoma evacuation. This is an endoscopic tool that allows us to see and aspirate the hematoma simultaneously, and we use navigation. So the endoscopic aspiration system is introduced through one of the channels of the scope. And then we always obtain a CT postoperatively. These are intraoperative pictures. That's my partner, Dr. Liebman. This is intraoperatively, you see the hematoma cavity. And then now you see actually a vessel sitting in the hematoma. It's not an aneurysm, it's a normal vessel, but it's probably what bled due to the hypertension, but the hematoma cavity is clear. And you can see pre versus post head CT. There's a good amount of volume of the hematoma was evacuated. So that would be an example of MIS clot evacuation. This is the tool, and it's unitized. It's an endoscope, aspirator, and navigation all in one handheld tool. Then we look at other trials such as the MISTY-2 and MISTY-3 trial. In these trials, a ventricular catheter was placed in the hematoma cavity, so not in the ventricle. And then alteplase is infused Q8 hours for up to 9 doses. MISTY-2 showed that this is a reasonable treatment and a safe treatment. And then MISTY-3 was looking more at outcomes. It showed there's no difference in good functional recovery, meaning MRS 0 to 3 at 1 year. And it's important to note that if you look at all of the ischemic stroke trials, good functional recovery is considered MRS 0 to 2. So in MISTY-3, they even kind of pushed that out to MRS of 3 as a good recovery. Again, because as I said earlier, the outcomes in hemorrhagic stroke tend to be worse. But there was not a difference in functional recovery. However, in the subgroup analysis, patients who had more clot removal or higher extent of clot removal tended to do better than those who had less clot removal. These are just examples of patients with a catheter in the hematoma cavity who were in the MISTY trial. This is a pre and then a catheter, and then this is a follow-up scan 4 weeks later after infusion of the alteplase. Now, I keep making this point because in all of these trials, it was crucial to understand the cause of the hemorrhage. And you can't enroll patients with vascular pathology in most of these, in the MISTY trial, for example. Here's an example of a patient with a ruptured MCA aneurysm. So if you don't look at this carefully, maybe you think this is a lobar hemorrhage, but really this is frontal temporal hemorrhage with a fair amount of subarachnoid hemorrhage. You see on the CTA that there's this ruptured MCA aneurysm pointing right at the hematoma cavity. That would be a disaster if you put a catheter in there and started to infuse alteplase. So this patient required a craniectomy, clot evacuation, and aneurysm clipping. Here's a 3D view of that aneurysm. So in terms of surgical intervention, I'm going to move from minimally invasive ICH to IVH surgical management. So with interventricular hemorrhage, if it's a spontaneous IVH with obstructive hydrocephalus, EVD, external ventricular drain, is recommended class 1 evidence to reduce mortality, and again, 2B for functional outcome benefit. And if you have spontaneous ICH of less than 30 cc's and IVH, again, EVD is recommended. And then if you go the next step into the clear IVH or MISTY trial, infusing a thrombolytic such as alteplase, there is no clear or not well-established functional outcome benefit with doing the EVD plus the thrombolytic, but it is reasonable to do. What I will say is I'll show on the next case with a patient in the clear IVH trial, the thrombolytic does keep the drain patent. And so in a way that reduces morbidity because every time you have to switch out a drain because it becomes clogged, there's risk of additional intracerebral hemorrhage or complication. So this is a patient with intraventricular hemorrhage and an EVD, and the intraventricular hemorrhage is from this AVM. So the EVD was placed initially for the hydrocephalus. Then we have to treat the cause of the bleed. which is this tiny intranidal aneurysm pointing right at the ventricle. That aneurysm was embolized with glue. And then once we were comfortable that the source of the hemorrhage was addressed, now we can start to infuse thrombolytic through the EVD. And again, no revision of the EVD was required. And you can see on this each day as CAT scans were done, the ventricles start to clear up. And then the patient comes in comatose, he starts following commands just with placement of the drain to treat the hydrocephalus. But by day 20, the drain is out, he didn't require a shunt, and he's able to go to rehab. Intraventricular hemorrhage historically has a mortality rate of up to 90%, but we're actually seeing much lower mortality rates just with the ability to treat the hydrocephalus. And this is his scan 19 days post-hemorrhage, and he was actually doing well. So what about craniotomy for supratentorial hemorrhage? This comes from old data, the Stitch trial. Craniotomy for hematoma evacuation does improve mortality, but whether it reduces functional outcome is uncertain. The Stitch trial, there was Stitch 1 and Stitch 2, essentially found that craniotomy is helpful in the patient who is deteriorating or herniating to prevent mortality, but didn't necessarily improve outcome. And that goes for craniectomy as well. Craniotomy, we put the bone back on. Craniectomy, we leave the bone off. I would say in 99% of hemorrhagic stroke, I'm performing craniectomy because of that secondary edema that I talked about earlier. The brain is still going to swell even if the clot has been decompressed. So again, in the Stitch trial, there's no superiority over surgical versus medical management unless the clot is superficial. We found that in the post hoc analysis, superficial clots do benefit from surgery. And then in Stitch 2, again, there is a survival advantage in craniotomy and hematoma evacuation, but again, does not decrease disability. And that was really why we did all of these minimally invasive trials, because we always said, it doesn't make sense. You know, if you remove the clot, take off the pressure, it doesn't make sense that the patients don't do better. Maybe it's our technique. Maybe if we do less damage going in to evacuate the clot, then the patients should do better. And we're still reviewing the data on a lot of these trials, sort of post hoc analysis to see which patients do better. Is it the superficial hemorrhage, a lobar hemorrhage? Which patients can we actually help with the minimally invasive treatments? This patient, you can see, has this sort of basal ganglia and thalamus hemorrhage and IVH. And just between the plain CAT scan and the CTA, the hematoma expanded. There's more midline shift. And so this patient underwent craniectomy, the bone is off, and clot evacuation. Now, one exception to the Stitch data is in posterior fossa or cerebellar hematomas. So in patients with a cerebellar ICH, if there's neurological deterioration, brainstem compression, obstructive hydrocephalus, or ICH volume greater than 15 cc's, surgical evacuation and EVD is recommended to reduce mortality. These patients do tend to do better post-operatively. This is a 51-year-old male who has AFib. He's anticoagulated. He collapsed at work, and he has this fourth ventricular and cerebellar hemorrhage with mixed density blood. The mixed density tells me that there's a hyperacute component to it as well. Just more scans of the same thing. He has a cerebellar AVM that is actually not in the location of the hemorrhage. The location of the hemorrhage is in the fourth ventricle, which is where this posterior inferior cerebellar aneurysm is pointed. And that's what we would call a flow-related aneurysm. And we are able to embolize that aneurysm because that is the source of the hemorrhage, prevent rebleeding because we don't want it to rupture on us when we evacuate the clot. You can see coils in the aneurysm here. And then now the patient goes for craniectomy, clot evacuation, and ventriculostomy. So one important thing that we do, and probably one of the most common things we do, is talk to families and talk about prognosis. The ICH score is just one component of how we prognosticate for families. But as you know, in real estate, location, 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 it's the same with hemorrhagic stroke. That has a lot to do with the prognosis as well. So it's reasonable to use an ICH score to talk about a framework of communication for the families, but it should not be the only guide that we use to talk about prognosis. And so that's actually one of their big recommendations, is not to use ICH score alone, which we never do. We look at the whole clinical picture, exam on admission, which is very important, location of hemorrhage, and as well as the ICH score, and medical comorbidities as well, general health upon presentation and baseline MRS. Next, once we get the patient through the hospital stay, we don't want them coming back with another bleed. So uncontrolled hypertension counts for about 74% of ICH. So we tend to like to keep the blood pressure low, 130s to 180s, for long-term management to prevent hematoma recurrence. What about those patients who came in on oral anticoagulation? If a patient is high risk, such as has mechanical heart valve or LVAD, we tend to resume anticoagulation early. So I would tend to resume warfarin within 24, 48 hours, depending on the size of the hematoma, as long as the patient doesn't need surgery and as long as this CAT scan is stable. If the patient does require surgery and I had good hemostasis and surgery, I would want to resume anticoagulation in a patient with a mechanical heart valve within a week, but usually within 3 to 4 days. For non-valvular AFib, I think that you really have to weigh the risks, the benefits of resuming anticoagulation. I will typically wait at least a month and repeat a head CT at 4 weeks, make sure the hematoma has resolved before the discussion of resuming anticoagulation. Here the AHA-ASA says consider initiation 7 to 8 weeks as a 2B recommendation. And so it's not really fixed when to resume anticoagulation. I also think it has a lot to do with the patient's comorbidities, age, and risk of ischemic stroke from AFib as well. As you heard in the last talk, there is some potential association with high-dose statin and intracerebral hemorrhage. It's a 2B recommendation. Really, risks and benefits of statin on ICH outcomes and recurrence is uncertain. So that's just 2B, whether or not to use statin. I think you should just base that on the patient's lipid panel. And then long-term use of NSAIDs is potentially harmful with increased risk of ICH. And then just in terms of secondary prevention, we would counsel, as with any stroke, blood pressure control. Heavy alcohol use is actually associated more with hemorrhagic than ischemic stroke. And then, exercise, healthy lifestyle, and caregiver support. So in conclusion, the ICH score is still a key determinant of outcome, but certainly not the only determinant. Medical management of blood pressure and any coagulopathy is the initial step, but really the care that the patient gets in the hospital is just as crucial in preventing rebleeding and secondary insults. So the patient should really be have caregivers who are comfortable with the care of the hemorrhagic stroke. And then surgery is recommended for select patients. We're still trying to find that group of patients that we can improve the outcomes. And we're still doing the operations to prevent mortality, always trying to improve our techniques. And that's all I had. So thank you. Can take any questions.
Thank you, Dr. Binning. Any questions?
No online questions, Kate?
Nope, no online questions, and it doesn't appear to have any
Okay.
questions from the audience
That was a great
either.
talk, Mandy. Thank you very much for the talk and for your time.